And very warm welcome to our distinguished speakers, guests, and friends joining us from around the world. My name is Dr. Kalkida Lagao. I'm a policy associate from Women in Global Health, and I'm currently joining you from Addis Ababa, Ethiopia. I will be moderating this session, so I just want to make sure that you all know that there is a French and Spanish interpretation, so please select the language that you want. And there is also a chat and a Q&A box where you can introduce yourself, where you're from, and where you're based. Additionally, if you have any questions, also you can ask there. We can answer some of them live. If not, we will try to address them during the session. So we gather here today to commemorate the Universal Health Coverage Day that we all hear. This event is organized by Women in Global Health with its 4 chapters: Women in Global Health Kenya, India, Brazil, and Burkina Faso. And we have representatives from each chapters to discuss about gender responsive universal health coverage and what civil society organizations are doing and will be doing to implement the 2023 political declaration on UHC. So before introducing the panel, I want to introduce you to Dr. Rupa Dutt, who's the Executive Director and Co-founder of Women in Global Health, to give her opening remark. So Dr. Rupa, the floor is yours.
Thank you, Dr. Kalkadan Laku. Again, very much excited to be here with all of you on today, especially in this important critical moment as we reflect on universal health coverage. And this is coming a few days after the Human Rights Day. So a lot to reflect on. And foremost, I want to welcome all of our attendees and our panelists, and good morning, afternoon, and evening to all of you. I'm honored to welcome you to this important webinar hosted by Women in Global Health, focusing on advocating for gender-inclusive universal health coverage. We know that particularly from the insights of the civil society organization, our Women in Global Health chapters, that as we gather today in the spirit of Universal Health Coverage Day under the theme Health for All, Time for Action, we are presented with a unique opportunity to delve into the critical intersections of gender equality and health systems. This event is co-organized in collaboration with our chapters, Women in Global Health Kenya, Women in Global Health India, Women in Global Health Brazil, and Women in Global Health Burkina Faso. So really spanning a diverse group of our chapters around the world. The past years have underscored the urgent need to address the deep-rooted gender inequalities within our health systems. The COVID-19 pandemic has further emphasized the importance of integrating gender perspectives into the governance, design, financing, and delivery of health service. As we navigate the complexities of our global health landscape, it is crucial to recognize that achieving universal health coverage cannot be accomplished without dismantling the barriers that hinder access for vulnerable communities, particularly women and girls facing intersecting forms of discrimination. Just to give some of the background here, women are marginalized in the leadership roles driving health decision-making from parliamentarians to community levels. Women are the majority of the health workforce, but only hold 25% of leadership senior decision-making roles. The talent and perspectives and voices of women are critical to decision-making at all levels to ensure universal health coverage meets the needs of all genders. This day should be the moment we challenge power and privilege and call for gender-responsive universal coverage by advocating for all women health workers. Women are delivering health, but men are leading it, and we are losing out on their expertise every day. The 2030 Universal Health Coverage Political Declaration incorporated some of the language and commitments that will help address gender inequalities and support gender-responsive universal health coverage, and particularly those related to the health workforce and women's leadership. A lot has been gained. However, we have expected to see stronger commitments from our governments on key areas such as sexually reproductive health and rights. And on sexual reproductive health and rights, the declaration makes no progress. At Women in Global Health, we will continue to call for a variety of things, particularly gender equality in health systems leadership and decision-making at all levels, including the uses of quotas, targets, and all women shortlists for selection until gender parity is achieved, paying particular attention to geographical diversity. Second, we're calling for retaining and recruiting women health workers by ending gender inequities in health workforce, career opportunities, and pay. So, ending all forms of unpaid work in health systems and ensuring all health workers have safe, fairly paid work free from violence and sexual harassment, and protecting the physical and mental health of all health workers. Third, designing and properly resourcing and delivering health systems based on gender responsive policies and health services, ensuring the elimination of gender inequality and discrimination. Four, resourcing and delivering universal coverage, particularly such that universal access to sexually reproductive health services as essential services and mainstreaming them into national health policy frameworks. We need to monitor and evaluate progress toward universal coverage through data and analysis disaggregated by sex, race, gender identity, and other relevant stratifiers. And number five, incorporating community health workers into the formal health sector and paying them fairly as a matter of economic justice for women health workers and to strengthen the capacity of health systems. And during today's events, our distinguished speakers representing women in global health chapters from Kenya, Burkina Faso, Brazil, and India will share their invaluable experiences and insights. They will shed light on how civil society organizations, especially women in global health chapters, effectively advocate for gender-responsive universal coverage at the country level. Through their stories, we aim to promote the integration of gender perspectives in health policies, creating a platform for knowledge exchange and fostering effective advocacy strategies. As we engage in the panel discussion and explore the challenges hindering the implementation of the political declaration on UHC at the country level, let us collectively seek solutions. Our speakers will also provide their perspectives on the best ways civil society organizations can ensure that governments deliver on their commitments, particularly in achieving gender equality. In the spirit of collaboration, let us share ideas, lessons learned, practical strategies that have proven effective in mainstreaming gender considerations into health systems. By doing so, we contribute to the global movement advocating for health for all, leaving no one behind. I'm confident that today's discussions will inspire actionable insights, fostering a renewed commitment to gender-inclusive universal coverage. Together, let us pave the way for a more healthier and equitable future. So thank you all for joining in, and our panelists. We look forward to hearing from you, and I will pass the mic back on to you, Dr. Kalkadan Laku, to lead the session. Thank you.
Thank you, Dr. Rupa, who is the Executive Director and Co-founder of Women in Global Health, for your opening remark and also for the key message, 5 key messages that you just shared for UHC Day. So without further ado, I will introduce the panel for today and we'll start hearing from them. So the first panelist is Dr. Mercy Wanjala from Women in Global Health Kenya. She's a distinguished family physician and an advocate of primary health care, universal health coverage, and health equity. With an extensive background in global health and health system strengthening, her professional leadership extends to executive roles in organizations like Africa Forum Health for Primary Health Care, WONCA, Working Party for Equality and Patient Safety, and she's also, as I mentioned, member of Women in Global Health Kenya chapter. Additionally, she has been recognized with the awards such as the Young Family Doctors Rising Star Award from the African region of the World Organization of Family Doctors. Thank you, Dr. Mercy, for joining us. Our second panelist is Arushi Raj, who is a multidisciplinary researcher and communications consultant, currently working as the chapter's coordinator at Women in Global Health India chapter. At the chapter, she leads and supports research, strategic communication, advocacy on key areas such as gender-responsive health systems for achieving UHC, women's leadership initiatives in India, and empowering female-front health workers. She holds a master's degree in sociology from Delhi School of Economics, and previously she works at the Center for Social Research and National Human Rights Commission, India. And our third panelist is Habibu, who is a health economist and passionate about advocating for health equity and access to quality healthcare. As the member of Women in Global Health Burkina Faso, she is leading activities related to universal health coverage. She is currently an associate in health financing at Clinton Health Access Initiative, and which is an international NGO where she supports the Ministry of Health of Burkina Faso to achieve UHC by improving financial management system of the health facilities through digital solutions and capacity building. Our last but not least finalist is Gisela Foz, who holds a master's degree in public health and also a lawyer. She's currently serves as the research and advocacy lead for abortion data, contributed the field with a focus on evidence-based research and policy shaping in reproductive health. She is a member of Women in Global Health Brazil. So thank you all of our panelists for joining us. So I will be just calling your name. So it could be based on the introduction that just made. So the first question now that we're here on UHC Day and during the 2023 political declaration, governments have made a lot of commitments, especially on gender equality, women leadership and participation, and also about health workforce. Now, after the global consensus, the next step would be the role of national level implementation and work. And Women in Global Health, as one of fierce advocate of gender equality and civil society organization based in 53 with 53 chapters, would be one of the civil society organizations working towards implementation of the commitments. So what we want to hear from you as the first question that I will be asking you is, can you share what your chapter as a Woman in Global Health chapter has been doing to advocate for gender responsive UHC at the national level? So it could be the experience that you've done before and also what you're planning to do. So just one from you. Hello?
I'm sorry, Dr. Kalkidan, could you repeat that? I think you froze for a moment.
Okay. Can you share what your chapter has been doing to advocate for gender responsive universal health coverage based on the work that you do at your chapter?
Thank you very much. So one of the things that we began doing this year in terms of advocacy was engaging with the UHC Secretariat. And the UHC Secretariat is the one that's in charge of universal health coverage issues at the national level in the country. And the good thing about that is, one, it is led by a woman. So that is an advantage. So we engaged with the Secretariat and we talked to them about gender responsive UHC, and they have been very supportive in terms of advocacy. So one, we did a lot of advocacy with top level leadership of the various counties around the country, because they had an event where they were doing sensitization around universal health coverage and the new approach that the country is going to do. So during those meetings, we also had an opportunity to share with them about gender responsiveness in universal health coverage. And we did get a number of people who are potential champions that we plan to engage this coming year to continue the work at the county level. So we have select counties where we had top leadership express interest in becoming champions. So the other way we've been doing this is by visibility and increasing the voice and advocating for gender responsiveness in regional meetings, like the AHIPE meeting that is usually held every year in Africa. We have the Primary Healthcare Congress, the first Primary Healthcare Congress held by AMREF Health Africa here in Kenya. We also had representation there. So there are various other meetings that I can mention that we have had representation by Women in Global Health Kenya. And through these meetings and engagements, we have found that people want to hear more about the gender responsiveness. They want to engage more. So through those meetings, the other thing that we've been doing is trying to organize also bilateral engagements with different organizations that want to advocate for gender responsiveness in universal health coverage. And the other thing, of course, that we have been doing even within the chapter is also trying to sensitize members as well on what we're trying to do with gender responsiveness, because this is a term that is not very clear to many people. What do you mean by being gender responsive in looking at UHC and trying to tie that to the whole concept of universal health coverage? Leave no one behind. That means trying to educate people around who has been left behind, why they've been left behind, why we can't continue leaving them behind. So those are some of the activities that we have done as a chapter thus far to advocate for gender responsive UHC. Back to you, Dr. Kalkidan.
Thank you, Dr. Mercy, for all the activities that you've been doing. I'll come back to you with challenge and also opportunities, how to engage at the national level after we hear from other panelists. Now, let me pass it to Arushi. The same question, what you can tell us about what Women in Global Health India is doing at country level to ensure our global key advocacy measures are implemented, and how you're holding your government accountable. Thank you.
I think, first of all, hello, everybody, and I'm Arushi. I'm representing WGH India, and thank you for having me for this very important discussion. I think keeping gender as a focal point is very critical for responding to the diverse needs of people, but also shaping inclusive health policies. We already know that gender drives significant health outcomes, and gender inequality, it manifests in different ways, impacting people's lived realities and access to healthcare services and also health-seeking behavior. So India chapter has broadly focused on 3 key areas, which is first is research and evidence building, second is advocacy, and third is communications. So on the research and evidence building front, we are concluding landscape research analysis on UHC and gender equality in India, which involves a scoping review of existing literature and also collating evidence through secondary research. We're also in the process of actively engaging and identifying key stakeholders, including civil society organizations, grassroots organizations, health movements, and key actors who are working on gender equity and UHC in the country. So the idea behind this research work is because UHC is so vast and there is a need to assess the current state of evidence around UHC and gender in India, and also to bring it all together as learnings, gaps, initiatives that we can further build on. We're also working on a few writing outputs and publications to build more knowledge products around this theme. On the second area, which is advocacy, we have been actively participating and advocating for gender integrated UHC at the global and national platforms, so the World Health Assembly and the events around G20 in India. We're also seeing efforts extending beyond the core team. So we're looking at WGH India community at large, in which a bunch of our members came together to give recommendations on the draft of the menstrual health policy, which is being formulated in India. So we're also trying to leverage our networks of health experts and researchers and push for gender inclusive policies in India. Then we're also currently playing with the idea of building a short-term gender and UHC coalition of different organizations and creating a community of practice around it. So we're planning to hold a series of dialogues and discussions to bring in different stakeholders and identify key priorities that needs to be addressed. We're also thinking of developing a toolkit around this as a resource for understanding and promoting gender responsive UHC in India. And the third area, which is communications, we're actively trying to use advocacy messages on our social media platforms. And we're also very proud to announce that we have released our monthly newsletter this year, which has been on our agenda for years. And it's very well received in the community. And this year we kept the theme of the September issue as gender and UHC and created a resource list around that, looking at gender responsive UHC through a policy lens. Lastly, we're also hosting a virtual event this week itself, bringing together diverse perspectives on gender responsive UHC. So looking at it through the lens of health policy, digitalization, community health workers, SRHR, and diverse, gender diverse communities. So that's broadly our effort around UHC and gender that the India chapter has been undertaking.
Thank you so much, Arshi. Thank you so much for the highlights, especially the one that you mentioned about forming a coalition on UHC with other civil society organizations. Maybe you will expand later on it, how you plan to do that, because something that we advocate is like multi-stakeholder collaboration and also sharing among partners. Forming that coalition is also very important. So I will pass it to Habibu, our third panelist, to answer the same question about her chapter's activity and work, especially now post 2020 UHC high-level meeting.
Okay, so hi everyone. So thank you. So I'm Habibu Ouedraogo, and I'm a member of the Burkina Faso chapter for Women in Global Health. So in terms of activities, there are several activities that the chapter has been doing and that have planned for the UHC grant. So in August this year, one of our members participated to the UN high-level meeting on UHC in New York, where she delivered a statement and where the political declaration was adopted. And this year, we particularly wanted to focus on training of on UHC for our members, because it was really important for us to give them the basic knowledge on what UHC is, how it translates to Burkina Faso, what are the best practices in other countries, how do we communicate effectively on that. So in November, there were some training sessions that were organized with more than 30 members from the Burkina Faso chapter and other Francophone chapter from Women in Global Health. And one good thing about those trainings is that they were delivered by the UHC Secretariat himself, and also with two other specialists on UHC. So during those trainings, there were some advocacy messages that were developed. And as part of UHC Day, we are planning to share those messages on our network, to call for action for different targets. So for decision makers, for instance, we are calling for the reduction of direct payment for patients. For the health workers, we are also encouraging them to continue following the best practices, the best clinical practices. So next year, we have also other activities planned, and one of them is to identify some champions. I've heard that one of the chapters also is working on that. So we are working to identify 10 people, mostly adolescent and female leaders, that are doing the work at the forefront. And we are also going into rural areas, not necessarily staying at the central level, and we plan to award them and also showcase their work. There are also some evidence that we plan to work on with some policy briefs, because there's data that is lacking, especially in our context. So it's good to have those data to better advocate for gender and UHC. And maybe one final thing that I will add is that it's good to create to have like everyone that is working on UHC and create like a coalition between the CSOs, the different associations, the parliament, and other stakeholders that is working on the thing. So we plan to organize some public conferences to create this coalition and to further think about the solutions that we can take. So that's it for all of the activities that we plan this year and that we expect to work on next year. Thank you.
Thank you so much, Habibu, for the brief description. So now I'll pass it to Gisela Foz to introduce what they've been doing in Brazil. So yeah.
Hello, thank you so much, Doctor. I am Gisela. I am from the Brazilian chapter. I am here today really honored to share this space with my fellows. I am already inspired by everyone's work. The Brazilian chapter is a fairly new chapter. We had our official launch a year ago, and we have been working really hard with our communications. So we just put up our website. We have our social medias, Instagram, LinkedIn account, and we're also working in a podcast because we wanted to deliver the message in different formats so we can reach a wider audience. So our podcast will talk about health issues, but also we want to go to the storytelling of how healthcare workers manage their daily lives and the challenges they face. And we do want to focus on marginalized communities. We also have a survey on the status of women in health. And I think this is a really powerful thing from our chapter, that we have a diverse community of members, including people that are working in research, people working in communications and advocacy. So we are building this bridge between data and advocacy. We are creating connections and networking with the Ministry of Health and health councils around the country. And we also have taken many international opportunities to participate in panels like this one, but also at the Women Delivery. And we also took part at a policy brief reflecting on what is needed to advance gender responsive health systems and gender equity in pandemic preparedness, prevention, response, and recovery. And I thought that was such an amazing moment where we were able to share our experience, but also learn from experience elsewhere. And I feel like we have many things that we converge into. So this is really amazing to be part of.
Thank you so much. So maybe I'll start directly from you, Gisela, asking you the second question, which is especially there is a lot of challenge civil societies face when we try to implement or support the implementation of the political declaration, and generally when it comes to women in global health, to advocate our key messages. So what are the major challenges that you see specifically your chapter is currently facing while working with others, and also not only Women in Global Health Brazil, what is the landscape in Brazil for civil society organizations to engage further with their government when it comes to gender responsive universal health coverage or gender responsive health systems in general?
I feel like we cannot talk enough about investment. I'm here sharing the stage with a great economist, so I won't jump into that because it's not my area, but investment is definitely a part of a huge challenge, especially because very often governments see spending with health not as an investment, but as an expenditure. So it's really hard to change that mindset. And we have research showing that as you know, investing $1 could give you X dollars in return. So we need to push that into implementing public policy in health and push for more investment. We have seen a lot of backlash in healthcare investment for the past years, but also we know that COVID took a great share of that, and we need to understand how we can build back from that. There's also the fact that there are many, in Brazil especially, there are many criminalization of public health matters. So we can talk about drug abuse, abortion, sex workers, because when we talk about universal health coverage, we're talking about universal. So we cannot leave anyone behind. And we want to make sure that the healthcare system is accessible for everyone and is acceptable for everyone. And this goes down to not just criminalization, but also stigma and discrimination. And in Brazil, again, we have research showing there is a huge gender gap, but also a huge race gap. And we need to look to that with an intersectional approach so we can understand what are the barriers people are facing to access the healthcare system, but also the barriers people are facing to work in the healthcare system. Is there a lack of training? Is there a gap in payment? So yeah, are people getting enough rest when they're working in the healthcare system? So this is really important to bring up and shed a light on it so we can work on that. And there is also the fact that we need to have a multi-sectoral action approach, especially recovering from COVID. We have a lot of food insecurity, housing insecurity. So how can we work together with different ministries? So not just advocating directly with the Ministry of Health, but also looking for the Human Rights Ministry, but in the Development Ministry, and not just in the federal sphere, but trickling down to state and municipality, and not just the executive power, but also focusing on the Senate, House of Representatives, and people who could also be champions for universal health coverage.
Thank you. Thank you so much. And now let me pass the mic to Habibu to answer the same question, focusing not only at women in global health, but also in the region. What are the main challenges that we need to prioritize in order to advance gender-responsive UHC?
Okay, so thank you for the question. So just before answering the question, I just wanted to provide a bit more information on how UHC translates in Burkina Faso, and it's kind of the same thing in Francophone, other Francophone countries, but with a bit of difference. So in Burkina, we have a free care program that has been implemented in 2016, and for pregnant women and children under 5 years old. So that means for those targets, all essential services are free of charge, and this includes consultations, surgeries, family planning, screening of cervical cancer, and just recently radiotherapy. So despite this program and the changes that we've seen in terms of more access to services, there are some challenges, and this can affect the current political declaration. So the first one that comes into my mind is the political instability and the displacement of population due to terrorist attacks in the region. So currently we have more than 2 million people that are displaced, and with that, there are also some health facilities that are closed. We have about 300 of them, and another 300 that are functioning with limited resources. So with this condition, it's difficult for health workers, especially female, to continue working at community level, and so they move to the capital city. So we end up with a gap in those areas, and a need for social protection for those people that are moving. Another issue is funding. I think, yeah, the funding is an issue, particularly when it comes to allocating the resources to health facilities that need them the most. There's also the lack of data on gender gaps and drug shortages. But I think that there are some solutions that we can think of, and Burkina Faso, I think there's still some positive aspects that the country is currently working on. So Burkina Faso remains one of the countries in the region with the higher proportion that is allocated for health. So it's 15% of its budget. So I think it's very positive in terms of statistics. It shows that there's willingness behind of the authorities to invest on health and UHC. And another thing that I wanted to talk about is that there are actions at the community level. We have what we call the community health clubs. So it's a composition of members from the community that are working together to share knowledge on the importance of prevention, getting vaccinated, seeing a doctor. So there are actions that are happening at the grassroots level, and so far it's providing good results. So us as Women in Global Health Burkina Faso, these are some of the initiatives that we are supporting, and we plan to reach out to the heads of parliaments to further discuss on how we can contribute to this work. And maybe one last thing is that there are also discussions on how to extend the free care program to other populations, such as the old people and the working class. So thank you.
Thank you. Thank you so much, Abibuya. The challenge that you mentioned also passed to other regions, as mentioned earlier. So there is some overlapping challenge. I'm sure there will be some overlapping solutions as well. So now the same question for you, Arushi, especially on the challenge that you faced, and also probably anticipating coming years when it comes to holding government accountable and generally advocating not only for UHC, but working within the civil society space, working for gender equality, and has its own challenge implication that we all witness. So just want to understand your take on that. Thank you.
Thank you for this question. I think I am going to echo my colleague's point here. And one of the biggest challenges that we're facing at a chapter level is resource mobilization and funding. So again, we need more investment in putting in these resources for any of these activities to be sustainable. But at a more country level, if we look at the challenges, of course, there is an overlap in terms of, every country has low public expenditure and lack of health infrastructure, inequities in access and healthcare delivery. But the three things in the Indian context really stand out here. So it, as evidenced in the COVID-19 pandemic, in any emergency situations, women's needs, especially sexual and reproductive health needs, they largely get ignored or deprioritized. And the pandemic was a huge example of this. We saw a major lack of investment in SRHR and gaps in policies and implementation, which led to widening of existing gender disparities. There was increasing of care work on women, and there was also increasing gender-based violence, which is a very pertinent issue in India. So this just goes to show that the health systems are not built to respond to gender-specific health needs of women, and gender is always seen as an afterthought. And in a country like India, given its vastness and also the fact that public health systems are extremely overburdened, we're always in troubleshooting mode. Which is exactly why gender and other intersectionalities need to be built within systems, and also crisis preparedness and response, so that we can deal with health threats, emergencies, conflict situations, climate shocks, and disasters. The other thing that has sort of emerged over the last few decades is that the disease landscape of India has changed significantly. And there is an exponential rise of cases of non-communicable diseases, which is contributing to 62% of overall mortality in India. So if we look at girls and women, they're disproportionately impacted by NCDs due to socioeconomic inequalities, and also because they experience specific challenges, because women's health is often not prioritized even within families. They lack agency, decision-making power, financial resources, and are often just burdened with caregiving duties. So this problem of NCDs, it becomes even more complex when we look at its intersection with other vulnerabilities. So in the case of India, there has been a significant impact of NCDs on pregnant women and maternal mortality rates and child care in India. So these experiences of NCDs, they need to be understood through a gender lens. And last challenge, which I feel like it cannot be emphasized enough, is the lack of institutional support, formalization, and labor rights of community health workers, who are absolutely critical for the success of UHC everywhere. But specifically in India, the public health system is heavily reliant on community health workers, most of whom are women, who deliver these healthcare services to remote and vulnerable populations. But they're still operating at the margins of the healthcare system in very precarious states, in facing stigma, discrimination, and violence. So I feel like without prioritizing the health and the well-being of community health workers, we will not be able to achieve UHC.
Thank you so much, Arush, especially the last part that you mentioned echoes what Dr. Rupa earlier mentioned about. It's important to recognize the role community health workers are doing and how like the future, like regarding on compensation, retention mechanism should be designed for them, and they should be also protected from sexual exploitation, abuse, and harassment within the community. Thank you for highlighting that as well. Now I will pass it to Dr. Mercy to give us a context, more context on in Kenya, within the chapter, outside the chapter. Also, you have different counties with different designs. So just want to understand the landscape there as well. Thank you so much, Dr. Mercy.
So much. Thank you so much, Dr. Kalkidan. I think one of the things that I can say I am happy about today in Kenya is that we have the political will to drive universal health coverage. And that is one of the things that we need to recognize as both an advantage and disadvantage of declarations, and political declarations at that. Because one, they're just declarations, there's no enforcement mechanism, there's dependency on national will and good will from the political class that is there at the moment. So the advantage that we have in Kenya is, number one, all the way from the national level, the president and his team have committed to our fourth attempt at launching and implementing universal health coverage. So one of the things that at national level has been done in terms of policy, we have developed 4 new acts that are going to govern universal health coverage. So we have an act that deals with primary health. We have the Primary Healthcare Act that covers both community health services and primary healthcare services and delivery, which is very key because we know primary healthcare is a vehicle towards achieving universal health coverage. Then the second one is on the Social Health Insurance Act. So Kenya has chosen social health insurance as a vehicle to mobilize and finances and resources towards universal health coverage. And in that act, there are different kind of funds that cover different people in the community. So we have like the Primary Healthcare Fund that covers primary healthcare services. Then we have the Chronic Disease Care Fund that covers chronic diseases. Then we have the Emergency Care Fund that covers any sort of emergencies that may arise, because those are some of the areas that we're trying to cover financially through different financing models to ensure everyone is covered. Because remember, universal health coverage is all about ensuring everyone has access to quality healthcare without going into poverty. So the other thing that is being done from the primary healthcare front is one, starting from the bottom up, the community health services structures. We know that community health services have traditionally in most African countries been manned by community health workers who are uncompensated. But now with the new act, the Primary Healthcare Act that covers these services, they're going to be compensated. A stipend, yes, but a stipend at least is better than what they were having before, which was nothing. So this is, the stipend is a matching fund kind of stipend. So the national government matches what the county government pays. So if the county government pays $50, $100, then that is what the national government is matching. So that is another thing that has changed within the landscape of universal health coverage policy and delivery within the Kenyan context. So now we have the national government, then we have 47 other county governments. So these 47 county governments have some functions, some devolved healthcare functions. So we have what is now called, we're not calling it devolved as such because it's not fully devolved, but shared functions. So some of the functions are covered by the national government and some of the functions are covered by the county governments. But when it comes to primary healthcare service delivery, up to the what we call the level 5, which is the county referral facilities, that's covered by the county government. So now this is where it gets tricky, because a political declaration is not really a commitment. There's no enforcement mechanism behind it. It's dependent on political will. Sometimes it has a short-term focus because we focus on the political period. So after 5 years, I cannot tell you what the lifespan or the lives or what's going to be, what we're going to have after 5 years. But this is just what we have within the 5 years to accomplish in terms of universal health coverage. What is the other thing that I'm loving about this landscape? What I called earlier the UHC Secretariat is now the Directorate of Universal, the Directorate of Health Financing, which is very key because another key component that we forget sometimes when we're talking about universal health coverage is it has a lot to do with financing. Where do you get the money? How do you use that money? How do you efficiently and effectively use that money for everybody? So that is a very also critical thing that has happened. Now to say that with the global universal declaration on universal health coverage, it's very dependent on national goodwill. So if you look at your country, implementation will be different. Implementation over time will also be different. How much a CSO can engage is also going to be different, because when you look at WGH Kenya and why we're able to engage with now the current Director of Health Financing, it's one, because she's a woman like we are, which is a very key thing. So she understands what we're talking about. She's a woman in leadership, so she understands how women leadership changes various landscapes within the UHC space. So I think that was a big win for us in terms of engagement. So it made it quite easy to engage and also forge a relationship, which worked very well for us. But I'm going to echo some of the things that the panelists have mentioned. When you're engaging government, especially at the national level, you need resources. You're not going to call government officers for a meeting and not compensate for their time, not pay for the meeting space, right? That is standard. So you have to think about resources. The other thing you have to really think about is, what am I bringing to the table? They're engaging so many partners. What makes you uniquely qualified to have their time, to have them engage with you, to be around the table? Because at the end of it all, it's all about getting onto that table where national discussions are happening. So what is it that you're bringing to the table that other people are not? Why are you worth our time? So those are some of the things that even as a chapter we were thinking around and have had to think around. Then the other thing, of course, engaging with different levels of government, especially like the county government, you have to think about the lifespan of who you're engaging, because political positions have an expiry date. And sometimes that expiry date, you don't even know when it's going to be. So you can engage one person in office today, then tomorrow there's a different person in office. So then what do you do? So it's a question of having a contingency plan around that. You have to be very strategic around who you engage, how you engage them, and having a lifespan beyond that particular office. I think with that, I can give it back over to you, Dr. Kalkidan. Thank you.
Thank you so much. Thank you so much, Dr. Mercy. Those were actually powerful points that you mentioned, really, really important, and also aligns with the question that I was going to ask, especially how civil society organizations can ensure our government deliver their commitment. So that is exactly that. The approach that you mentioned is could be answered by that. But I'm going to come back. I'm going to continue asking you the question here. So you mentioned in Kenya, there is a huge political commitment to deliver UHC. So at Women in Global Health, that we're asking is beyond UHC. While we are thinking about UHC, how should we make it gender responsive? And we've been saying that women are the ones delivering health, but they're not leading it. So in that aspect, how is the government seeing this gender equality representation in the site of implementing universal health coverage, and how Women in Global Health can also support that work?
Thank you very much, Dr. Kalkidan. And I think one of the things that I think it was the colleague from India, Raj, mentioned was the issue of gender not being an afterthought. So unfortunately for us in Kenya, and I think for most people, is you're starting from it being an afterthought Like it's just brushed over and there's vague language around it. There's nothing specific that talks about it. So that is left to a lot of open interpretation. And that is left to us as civil society, us as WGH Kenya, to then bring it to the table and bring it loud and clear. So I think one of the things that we need to be loud and clear about is the message. Let's not just say gender responsiveness. What do we mean? So we have to break that down in a way that someone at policy and political level understands what we mean. And we're doing it in other simple ways through like advocacy around the issue. When we had the World Breastfeeding Day, where we were advocating for people to and institutions to actually have just room for breastfeeding. That's being gender responsive. So when you're making investment, think about investments that support women within the workplace, within their homes, within their communities. Simple things like having a place where you can wash your hands. That is very critical because the people, we also have to remember that women, just because we're all called women, doesn't mean we have the same context and the same challenges. So now the issue of how do I contextualize what I'm talking about in terms of gender responsiveness? When I move to the younger women who are adolescents who are in school, then I'm talking about, for example, having sanitary facilities. So they don't miss school because, they're having their menstrual period. So it depends on how you bring out the message for each group, how you break it down. Like, how do I say I'm being gender responsive in a rural area? How do I say I'm being gender responsive in the workplace? How do I say I'm being gender responsive in investment? How can I show that? With health financing, how do I show that? With how the funds are being used and how the funds are distributed, how can I show that there's gender responsiveness? How much is going into ensuring women are protected, for example, from emergencies that occur due to childbirth, like the aftermath? How do I see that I'm covering women for direct and indirect costs of moving from point A to B, delivery, and its other complications that arise that you have to deal with? So there's so many aspects to gender responsiveness that you have to break it down to your audience and be very clear. When I say I want gender responsiveness, this is what I mean at leadership level. This is what I mean at this leadership level, at national, at subnational, at community level, right? Like we mentioned, the community health workers. Who leads the community health workers? Is the voice of the woman clearly heard? Like the issue of security simply. You want a woman to be moving alone house to house, right? Anything can happen. So being gender responsive is being cognizant of the fact that this community health worker that you're sending around to move into people's houses has a vulnerability. So being gender responsive means you recognize that and you provide a policy that's going to protect them. So I think the biggest hurdle that we'll have to overcome and the biggest thing that we have to do is being very articulate and specific on the asks. Because that is a thing that we learned when we were engaging the different stakeholders across the counties. What is your ask? What do you want me to do? And I think one of the things that government love, when you go and you give them the solution, and you say, this is the ask, and this is how to do it, then they're very happy about it because they don't have to go and start rethinking things that they were not thinking about before. And I think that is an important part of engagement and trying to keep governments accountable. And now looking forward, gender equality and equity cannot be an afterthought anymore. So I think we need to be louder at every policy making table and bring it up. How are you doing A, B, C, D in response to women's needs, young girls' needs? How are you doing that? We want to see that. And I think the biggest thing is to ensure that we are on the table where these policies are being made and we bring it to the forefront such that when the policy comes out, it's not an afterthought. Because right now we are coming from the point of it's a bit of an afterthought. We cannot see how it has been woven into the current policy and structure. Back to you, Dr. Kalkidan.
Thank you. Thank you so much, Dr. Mirsi. That was clear and loud. That is something that we need to advocate as well. Gender equality cannot be afterthought anymore. So it could be one of the things that we should take as a takeaway on our UHC Day event as well. Thank you so much. So I will ask this question to Arushi. So it's a similar question as Dr. Mercy, specifically how the best way civil societies can ensure government deliver their commitment, especially in the political declaration. And as an organization, we're focusing on gender equality, equity, and women's representation. So how do we best engage with governments?
Thank you for that question. I think that's a very interesting question, but I won't say that I have a straightforward answer to that, because it is great to see that UHC is given priority on so many global health agendas, political declarations, commitments. But I feel like what's largely missing in this discourse is the political will of countries implementing them, which also needs to be backed by adequate resources and also voices from the ground realities. So given the current geopolitical situation, I really feel like any progress on UHC can only be achieved if accountability mechanisms are built within these high-level agreements and declarations. For example, even in the case of India, at an international level, we know that we're committed to these declarations, but there is no clarity on the implementation guidelines at a national level or how India plans to uphold these commitments. So national health policies and strategies, they need to reflect these international agreements. And it should be based on legal frameworks, which is backed by institutional capacities to respond to people's needs. I think another important question that we need to raise and reflect on is how do these commitments and agreements percolate to the ground realities? Because there seems to be a bit of a disconnect between the ground realities and these declarations. Because I genuinely feel like civil society organizations are already doing a fantastic job of complementing the public health systems at the local level and also helping respond to local needs and realities. But these efforts and capacities, they need to be strengthened, maybe through incorporating an emergency preparedness lens, but also they need to be represented and amplified. So I don't think there is a single way or a single path to achieving UHC, and considering that we are at a different stage of implementation, I feel like the most important thing here is to bring in voices from the ground level to these meetings and declarations, and having a more participatory and inclusive approach where local governments and civil society organizations can work in collaboration. So as CSOs, we can also think about more collaboration and aligning our efforts to support and amplify the already existing work that's been done on the ground level. Yeah.
Thank you so much, Arushi, for highlighting the points and also sharing the experience that you have in India to emphasize that. Thank you. Now I'll pass it to Habibu to answer the similar question, but in the context of your chapter in your country, focusing in your country, how we best should engage with the government.
Okay, so thank you, Dr. Kalkinda. So one thing that comes into my mind when it comes to translating the political declaration on the ground to make sure that it has impact is to create allies with the stakeholders that are at the right tables. I think oftentimes civil society organizations are often left out and not included in those discussions. And my colleague from Kenya, she said that it's very important to be specific about the ask. So And also she said that financing also depends on the Directorate of Financing for resource mobilization. So I think when it comes to ask, we also need to be clear about what are the statistics that we need and what is the impact intended afterwards. So for me, it would be creating a LIS and if necessary, also creating a committee to monitor the progress of all those activities on the ground and check if they are working. Another thing will be to also better communicate with advocacy messages, calling for actions both at the national and also the subnational level, because we should not forget about the people at the district and regional level. I'll probably end by saying that we shouldn't always wait for the government to take actions. As a civil society organization, we could work with the community to do some small action, let's say a campaign for vaccination, or maybe something like a reach out campaign to share the good aspect of doing the vaccination, or it could be like something small, like cleaning like a community area for prevention stuff. So I think the civil society should not wait for the governments to do the action, and when possible, create allies with the right decision makers, with key statistics, with the right ask. Thank you.
Thank you so much, Habibu. Well said. So now I'll pass it to Ms. Gisela to answer the same question, but in your context, especially implementing the commitments on gender equality within the political declaration.
Sure, thank you. One thing I would like to highlight is that the right to health in Brazil is a constitutional right. So that makes things a little bit easier on our side because we can claim access to healthcare in our Supreme Court. And we do have a healthcare system that is universal and anyone should be able to access. There is a problem with financing it, and definitely a huge line for some specific situations and places geographically, because Brazil is a huge country. So there are many particularities that we need to take into account. But in paper, in our strongest legal instrument, we have that right. So that does brings a lot of support to our work. We do have a huge barrier in accessing those geographical places. As a chapter in Brazil, we wanted to make sure that people can come to us and we can get to people, especially because there is a language barrier. So we are trying to adjust that. We understand that many people in Brazil don't speak English, and when you have that name in English, it might be a shock for people. So we want to make sure that our chapter is out there and available to gather people's experience, because we do believe that the grassroots, it's where the solutions are. I have a personal experience working with youth, and it is very interesting to see how much you can learn from just listening to people. So to create those spaces, to survey and to empower civil society to be able to share the solutions they already have when it comes to healthcare access, because they know the barriers they're facing, and very often they have the solutions to overcome the barriers. It's really powerful. So I would say that this is one of the main things that we need to focus on. Put the grassroots at the center. We do have a political will. Currently, we have an executive government that is willing to, take civil society participation. But there's in the democracy political context there's a lot to compromise, especially when you have to take into account also the legislative and the judiciary. So even though we have the political will, we need to push the boundary. We need to hold them accountable, because unfortunately, women's rights, vulnerable communities' rights are the first ones that will be up for grab. So it's really important for us to commit with what we're doing and make sure that we don't step back, because we don't have to compromise universal health coverage. This is our main agenda. And we need to hold the government accountable, regardless if the government is someone we voted for, someone we support, and regardless of, political party. It's really important that we don't step back. So we need to look at that from a very, I would say, practical perspective, and make sure that representation trickles down to participation, because very often it happens not just in the federal sphere, but in every sphere. They want to claim that, oh no, we have included one woman in our work, and that's not enough. We want equality, we want equity, we want more women in leadership roles, and we also want people in general who are compromised with closing the gender gap. So it's not just making sure that we have someone there, and we want to make sure that person is not a token. So we want the representation to actually means participation.
Thank you. Really strong points here. I'm taking a lot of notes. So thank you so much for all of you for highlighting answering the questions and highlighting the importance of gender equity when we talk about universal health coverage. So I've seen quite a few questions in the Q&A box, and thank you so much for all the panelists for answering them right away. Just want to highlight, there was a question that whether we have a chapter in Zambia, and yes, we do, and we'll be linking you. But in case anyone is interested, I just put in the chat our webpage with all our chapters. So new chapters are always being established, and we are now at the 53rd. So please join our chapters, and I will definitely link you with the Zambian chapter. I just want to, if you have more questions, you can put it in the chat or in the Q&A, and we will address them. In the meantime, I just want to give one chance for from my side, for all the panelists. You will go one by one. What is one key message that you want to give for a participant, or your generally your UHC Day message for you? So we'll give you 1 minute to wrap up with one message that you want to share to the world. So let me start, Habibu.
Thank you. So one message would be to think about what is working in other countries, and also see what can work in our country. I think there are, with the experiences that the chapter shared, I think there are already some work that is done at the country level, but in case there are examples in other countries that can be applied and adapted and contextualized, I think that would be good. Maybe one other thing to add is to create allies, generate enough evidence, and be at the right decision table with the right stakeholders to progress on UHC. Thank you.
So much. Message well received. So Arushi.
Yeah, thank you for having us. I think it was great hearing from every country's perspective, and also reflecting and learning from their journeys with UHC. I would just like to reiterate that we are currently in a very fragile political climate, and as we progress towards UHC, I don't think gender can be seen as a separate entity or like an afterthought. It needs to be integrated within perspectives, within frameworks, with nuances and intersectionalities in mind, which means that there needs to be equitable representation of everyone's needs, interests, rights, and also voices.
Thank you. Thank you, Arushi. So pass it to Gisela.
My message would be organize yourself. It's either in a Women in Global Health chapter or in your local community. There's always room for you to organize yourself politically and as a civil society individual. And there's a lot of power in your voice and in whatever you want to push it forward.
Thank you. Last but not least, Dr. Mercy.
Thank you. I think I'm going to incorporate one of my favorite quotes in this, and that is, some is not a number, soon is not a time. Gender responsive UHC now. That is to mean, do what you can, where you are, every day. If you're seeing patients clinically, make it gender responsive. Respond to the needs of those women and girls that you see. If you're working in a school, if you're working for rights, you can do something now. And then now you can call other people to join you if you don't have other people to join. Or you can go join other people who are doing what you do. But don't forget that you can do something now. So go and do it. Thank you.
Thank you so much, Dr. Mercy. Your message is well received. So now we're about to close, but before closing, we have another guest of honor who will be doing our closing remark. So Dr. Shabnam Sarfaz, yes, she's here. I just want to make sure. She's our Deputy Executive Director of Women in Global Health and co-founder of Women in Global Health Pakistan. She will wrap up today's event by her closing remarks. So without further ado, I just want to give the chance for Dr. Shabnam to close the event. Thank you, everyone, for your engagement.
Thank you so much, Kalkidan. Thank you. I hope you can all hear me well. Dear participants, as we close this inspiring webinar, I'm filled with gratitude for the wealth of insights and perspectives that you've all shared today by our esteemed panelists representing Women in Global Health Chapter from Kenya, Burkina Faso, Brazil, and India, and our moderator, Kalkidan, for steering so effectively the discussions today. We all know that universal health coverage will be the game changer in the lives of billions of people who dread getting ill themselves or live in fear that their children might get ill, knowing that they could never afford the cost of quality health care. For too many people, illness means death or destitution, unnecessary suffering, and premature death. In countries like mine, Pakistan, access to quality, affordable healthcare is still a challenging feat for most, especially for women. These are the political determinants of health. In September, the member states met at the UN for a second UN high-level meeting on UHC and reaffirmed their commitment to realizing UHC everywhere for everyone. The challenges outlined by our panelists underscore the complex factors involved in implementing the political declaration on UHC at the national level and how CSOs must collaborate to hold governments accountable for their commitments. The unwavering commitment and innovative approaches to promoting gender-responsive UHC are truly commendable. From Kenya to Brazil, from Burkina Faso to India, as we reflect on the main takeaways for today's events, it is clear that the integration of gender perspective into health policies is not merely a choice, but an imperative. The intersectionality of health, gender, and equity demands our continued attention, collaborative efforts, and sustained advocacy. Women are the backbone of our health systems, but to truly achieve universal health coverage, we must pave their path to success, as it is women who will deliver it. I want to leave you with 4 points that will enable women health workers to deliver universal health coverage. We must continue to promote equal participation of men and women in health leadership. We must also protect women health workers against violence and harassment. Last year, our Global Health, Women in Global Health published report with harrowing testimonies from women health workers of sexual harassment, exploitation, and abuse by patients, by colleagues, and men in the community. This human right abuse causes real harm to women and also causes wider damage to health systems delivery. We also need to recognize the value of unpaid work, largely done by women in the sector, and the importance of equal pay. Last year, a Women in Global Health report identified over 6 million women working unpaid and grossly underpaid in core health system roles. Lastly, we need to ensure safe and decent work conditions. It is important to prioritize the mental health support. A healthy workforce is indeed the key to achieving universal health coverage. Remember, health for all, time for action isn't just a phrase. It's a rallying cry. Let's build a world where health knows no bounds and equity is the cornerstone. Thank you all for the wonderful deliberations that we've had today through your interactions and through your sharing of expertise and experiences. Thank you for your commitment to this cause. With this, we may close the webinar. Thank you so much. Thank you, Kalkidan, and the panelists again.
Thank you, everyone. Thank you.
Bye-bye.